Cerebrovascular disease kills more seniors than most cancers combined, yet the warning signs go unrecognized for months or years before catastrophic events occur. Strokes don't strike randomly from nowhere. They announce themselves through subtle symptoms that seniors dismiss as normal aging, arthritis, or stress. Understanding cerebrovascular disease requires grasping what the term means. Cerebrovascular refers to blood vessels supplying the brain with oxygen and nutrients constantly. Disease means these vessels are damaged, narrowed, blocked, or weakened, compromising blood flow to brain tissue. The brain requires 20% of the body's total blood flow, despite being only 2% of body weight. This enormous demand means even small reductions in blood flow cause brain tissue damage rapidly. Brain cells begin dying within minutes of oxygen deprivation, unlike other organs that can survive longer periods of ischemia. Cerebrovascular disease encompasses multiple conditions affecting brain blood vessels. Atherosclerosis involves plaque buildup inside carotid and vertebral arteries supplying the brain, narrowing vessel lumens and reducing flow. Small vessel disease affects tiny arterioles deep in the brain, causing chronic ischemia and white matter damage. Aneurysms are weakened bulging areas in arterial walls that can rupture, causing hemorrhagic stroke. Arterial dissection involves tearing of arterial walls, creating false channels that block blood flow. These conditions develop silently over years before causing obvious symptoms. By the time stroke occurs, vessels are severely diseased throughout the brain's vascular tree. But warning signs appear months to years before major strokes if you recognize them. The challenge is that cerebrovascular disease warning signs are subtle, intermittent, and easily attributed to other causes. Lower back pain gets blamed on arthritis. Vision changes get dismissed as needing new glasses. Dizziness gets attributed to inner ear problems. Bladder urgency gets chalked up to aging. But when these symptoms result from cerebrovascular disease affecting specific brain regions, they predict imminent stroke requiring urgent intervention to prevent catastrophic events. Research published in Stroke Journal documented that 80 to 90% of stroke patients experienced warning symptoms in the weeks to months before their stroke. Most ignored these symptoms or attributed them to benign causes. Those who sought medical evaluation and received treatment had dramatically reduced stroke risk through medications, lifestyle changes, or procedures correcting vascular problems. The 8 cerebrovascular disease signs discussed in this video represent those most commonly missed by seniors because they seem unrelated to brain or vascular health. Each sign is explained with the vascular mechanism causing symptoms, the brain regions affected by reduced blood flow, statistics on how often these warnings precede stroke, and critical actions to take when recognizing these signs. These warnings come from major stroke research, including the Framingham Heart Study, the Rotterdam Study, NIH stroke prevention trials, and American Heart Association stroke warning guidelines. Understanding these signs empowers seniors to seek timely evaluation before irreversible brain damage occurs. Stroke is largely preventable when risk factors are identified and treated aggressively before vessel disease progresses to complete occlusion. The goal isn't creating anxiety about every symptom. The goal is recognizing patterns of symptoms indicating brain ischemia, requiring urgent vascular assessment and intervention. Click subscribe right now, leave a like for the algorithm, share with anyone over 60 who needs this information. Comment which sign you recognize from your own experience. Now let's examine 8 cerebrovascular disease signs seniors ignore, starting with number 8 and building to the most overlooked, the one appearing in the lower back and pelvis that 90% of seniors attribute to arthritis when it actually indicates vertebral artery disease, predicting brainstem stroke. Sign number 8. Sudden onset of severe headache, different from any previous headache experienced. Sudden severe headache represents the classic warning sign of cerebrovascular catastrophe, yet many seniors delay seeking care, hoping the headache will resolve spontaneously or attributing it to sinus problems, stress, or medication side effects. The headache of cerebrovascular disease has characteristic features distinguishing it from tension headaches, migraines, or sinus headaches. It begins suddenly, reaching maximum intensity within seconds to minutes rather than building gradually. Patients describe it as the worst headache of my life or thunderclap headache, terminology indicating dangerous pathology. The mechanism involves several cerebrovascular emergencies. Subarachnoid hemorrhage from ruptured aneurysm causes sudden severe headache from blood-irritating meninges surrounding the brain. The blood triggers intense inflammation and increased intracranial pressure, creating pain receptors in meninges. Intracerebral hemorrhage from hypertensive arteriopathy or arteriovenous malformation rupture causes headache from rapidly expanding blood volume, increasing pressure inside the rigid skull. Brain tissue compression and edema activate pain pathways. Vertebral artery dissection, where the arterial wall tears spontaneously or from minor trauma, causes severe neck and head pain from stretching of pain receptors in the arterial wall. The pain is often unilateral, affecting the side of dissection. Carotid artery dissection causes similar ipsilateral head, face, and neck pain from arterial wall tearing and stretching. Research published in Lancet Neurology found that sudden severe headache precedes subarachnoid hemorrhage by hours to days in 30 to 40% of cases. These sentinel headaches represent warning leaks before major rupture. Patients seeking care for sentinel headaches and receiving treatment have dramatically better outcomes than those experiencing major rupture without warning. What makes this sign dangerous is that many seniors take pain medications and wait rather than seeking emergency evaluation. Hours to days later, major hemorrhage occurs with devastating consequences, including death in 40 to 50%, severe disability in another 25 to 30%, and good recovery in only 20 to 30%. What you must do if experiencing sudden severe headache is call 911 immediately, without delay. Do not drive yourself or have family drive you. Paramedics can begin treatment during transport and alert the receiving hospital to prepare for potential stroke, requiring immediate imaging and intervention. Do not take pain medications before evaluation, because this can mask symptoms that neurologists need to assess. Do not eat or drink anything, because you may need emergency surgery requiring empty stomach. At the hospital, immediate CT scan determines whether hemorrhage is present. If subarachnoid hemorrhage is confirmed, CT angiography or conventional angiography identifies the bleeding source, usually an aneurysm requiring urgent surgical clipping or endovascular coiling to prevent rebleeding. Time is critical because rebleeding risk is highest in the first 24 to 72 hours after initial hemorrhage, and rebleeding carries even higher mortality than initial bleeding. Sign number 7. Transient vision loss or vision changes in one eye lasting minutes. Sudden vision loss in one eye lasting minutes to hours represents a critical cerebrovascular warning sign called Amaurosis Fugax, meaning, quote, fleeting blindness. This symptom indicates emboli from carotid artery atherosclerotic plaque traveling into the ophthalmic artery, supplying the retina with blood. Patients describe a curtain or shade coming down over one eye, blocking vision partially or completely. The vision loss is painless, affecting one eye only, and resolves completely within minutes to hours as the embolus breaks up and passes through the retinal circulation. The mechanism involves carotid artery stenosis from atherosclerotic plaque buildup, narrowing the vessel lumen. The plaque surface becomes irregular and unstable, with cholesterol crystals and platelet aggregates breaking off and traveling downstream into smaller arteries. When these emboli enter the ophthalmic artery, the first branch off the internal carotid artery supplying the eye, they temporarily block retinal arteries, causing ischemia to retinal cells and sudden vision loss. As the embolus fragments and flows through, vision returns. This symptom is a dire warning because the same carotid plaque shedding emboli to the eye can shed larger emboli to the brain, causing stroke. Research shows that patients experiencing Amaurosis Fugax have 15 to 20% risk of major stroke within 3 months if carotid stenosis isn't identified and treated urgently. Additionally, some patients experience permanent vision loss from central retinal artery occlusion if the embolus is large enough to completely block the main retinal artery. This constitutes an ophthalmologic emergency, requiring immediate treatment within 90 minutes to preserve vision. Beyond emboli, other cerebrovascular causes of transient vision loss include vertebral insufficiency affecting the occipital cortex where vision is processed, giant cell arteritis, temporal arteritis, causing inflammatory vessel occlusion, and hypoperfusion from severe carotid stenosis, reducing blood flow to the eye during position changes. What you must do if experiencing sudden vision loss in one eye, even if it resolves completely, is seek emergency evaluation immediately. This is not a wait-and-see symptom. This is a medical emergency requiring urgent vascular imaging. At the emergency department, carotid ultrasound measures blood flow through carotid arteries and identifies stenosis severity. If severe stenosis greater than 70% is found, carotid endarterectomy surgery or carotid stenting should be performed within days to prevent stroke. If moderate stenosis, 50 to 69%, is found, aggressive medical management with antiplatelet therapy, aspirin plus clopidogrel, high-dose statin therapy, blood pressure control, and smoking cessation reduces stroke risk substantially. Ophthalmology consultation examines the retina looking for emboli visible in retinal vessels, Hollenhorst plaques, cholesterol crystals, arterial occlusions, or signs of giant cell arteritis requiring immediate steroid treatment. Time is critical because stroke risk is highest in the first 72 hours to 1 week after Amaurosis Fugax. Intervention during this window prevents the majority of strokes. Sign number 6. Unexplained dizziness, vertigo, or balance problems appearing suddenly. Sudden onset of severe dizziness, room-spinning vertigo, or balance problems causing difficulty walking represents a critical warning sign of posterior circulation cerebrovascular disease affecting the brainstem and cerebellum. The posterior circulation includes vertebral arteries ascending through the cervical spine and basilar artery formed by vertebral artery convergence, supplying the brainstem, cerebellum, and occipital lobes with blood. These structures control balance, coordination, vision, and consciousness. When vertebral or basilar arteries become narrowed from atherosclerosis or occluded by emboli or thrombosis, the brain regions they supply become ischemic, producing characteristic symptoms including severe vertigo, sensation of room spinning uncontrollably, ataxia, inability to walk straight veering to one side, diplopia, double vision from brainstem cranial nerve ischemia, dysarthria, slurred speech from brainstem motor pathway involvement, and dysphagia, difficulty swallowing. These symptoms together constitute posterior circulation transient ischemic attack, TIA, or stroke, requiring emergency evaluation because basilar artery occlusion carries extremely high mortality, 70 to 80%, even with treatment. The challenge is distinguishing posterior circulation ischemia from benign peripheral vertigo caused by inner ear disorders like benign paroxysmal positional vertigo, BPPV. Key distinguishing features include associated neurological symptoms, double vision, numbness, weakness, speech difficulty, inability to walk even with assistance, severe persistent headache, particularly occipital, and risk factors for stroke, hypertension, diabetes, prior TIA or stroke, smoking. Research shows that patients presenting with acute vertigo and vascular risk factors have posterior circulation stroke in 10 to 15% of cases. Missing these strokes leads to progression to complete basilar occlusion with devastating outcomes. What you must do if experiencing sudden severe dizziness with any associated neurological symptoms is call 911 immediately. Lie down flat to maximize blood flow to the brain through gravity assistance. Do not attempt to walk because falling could cause additional injuries. At the emergency department, MRI with diffusion-weighted imaging detects acute ischemic stroke in the brainstem or cerebellum with high sensitivity. CT angiography evaluates vertebral and basilar arteries for stenosis, occlusion, or dissection. If acute stroke is confirmed within the treatment window, thrombolytic therapy, TPA, or mechanical thrombectomy can restore blood flow and prevent permanent disability. If vertebral artery stenosis is found, antiplatelet therapy and blood pressure control reduce future stroke risk. Sign number 5. Lower back pain with bladder urgency or pelvic discomfort, indicating vertebral artery disease, most overlooked sign. Lower back pain combined with bladder urgency, pelvic pressure, or unusual pelvic sensations represents the most overlooked cerebrovascular disease warning sign because seniors universally attribute these symptoms to arthritis, urinary tract infection, or prostate problems in men. But when these symptoms result from vertebral artery disease causing ischemia to specific spinal cord regions and brainstem areas controlling bladder and pelvic sensation, they predict imminent posterior circulation stroke requiring urgent intervention. The mechanism involves vertebral arteries that ascend through small bony channels, transverse foramina, in cervical vertebrae before entering the skull and joining to form the basilar artery. These arteries give off small branches supplying the spinal cord in the neck region. Atherosclerotic disease, or dissection of vertebral arteries, reduces blood flow not only to the brain but also to the upper cervical spinal cord. This causes ischemia to sensory and motor pathways traveling through the cord, producing symptoms including neck pain radiating to lower back, unusual pelvic sensations or pressure, bladder urgency from autonomic pathway involvement, and leg weakness or numbness from motor and sensory tract ischemia. The lower back pain from vertebral artery disease has characteristic features. It's often unilateral, affecting the side of arterial involvement. It's associated with neck stiffness or pain. It worsens with head turning or neck extension, and it's accompanied by neurological symptoms like dizziness, vision changes, or difficulty swallowing. Research shows that vertebral artery dissection, a common cause of these symptoms, often follows minor neck trauma including chiropractic manipulation, whiplash from motor vehicle accidents, vigorous exercise, or even forceful coughing or sneezing. Patients develop neck and head pain hours to days after the event, followed by posterior circulation stroke within days to weeks if dissection isn't diagnosed. The bladder urgency and pelvic symptoms occur because autonomic pathways controlling these functions travel through the brainstem and upper spinal cord. Ischemia to these regions disrupts normal bladder control signals, creating urgency, frequency, or unusual pelvic sensations that seniors misinterpret as urinary tract infection or prostate enlargement. What you must do if experiencing lower back pain with associated neck pain, dizziness, bladder changes, or pelvic discomfort is seek urgent medical evaluation with specific mention of these symptom combinations. Don't accept reassurance that it's just arthritis without proper vascular assessment. Request MRI of the neck with Mr. Angiography of vertebral arteries to evaluate for dissection or stenosis. CT angiography is an alternative if MRI is unavailable or contraindicated. If vertebral artery dissection is found, anticoagulation therapy with heparin transitioning to warfarin or direct oral anticoagulants prevents thrombus formation and embolization that causes stroke. Treatment continues for 3 to 6 months until the arterial wall heals. If severe vertebral artery stenosis is found, antiplatelet therapy and risk factor management reduce stroke risk, though interventional procedures are less commonly performed on vertebral arteries compared to carotid arteries. Sign number 4. Difficulty speaking, slurred speech, or word-finding problems appearing suddenly. Sudden difficulty speaking, slurred speech, dysarthria, or inability to find words, aphasia, represents classic stroke symptoms that most people recognize. Yet many seniors experience these symptoms transiently, lasting minutes to hours before resolving, and fail to seek immediate evaluation, not realizing these represent transient ischemic attacks, TIAs, predicting major stroke. The mechanism involves ischemia to brain regions controlling language and speech production. Broca's area in the dominant frontal lobe controls speech production. Ischemia here causes non-fluent aphasia, where patients understand language but cannot produce words fluently, speaking in short telegraphic phrases with great effort. Wernicke's area in the dominant temporal lobe controls language comprehension. Ischemia here causes fluent aphasia, where patients speak smoothly but with nonsensical word substitutions and cannot understand spoken or written language. Dysarthria, slurred speech without language impairment, results from brainstem or cerebellar ischemia affecting cranial nerves controlling tongue, lips, and throat muscles required for articulation. Research shows that transient speech difficulty predicts major stroke within 7 days in 15 to 20% of patients if TIA cause isn't identified and treated. The risk is highest within the first 24 to 72 hours, creating a narrow window for intervention. What you must do if experiencing any speech difficulty, even if it resolves completely, is call 911 immediately. Time is brain tissue. Every minute of delayed treatment allows more neurons dying from oxygen deprivation. The FAST acronym helps recognize stroke, face drooping on one side, arm weakness or drift when both arms raised, speech difficulty or slurred words. Time to call 911 immediately. At the emergency department, immediate brain imaging with CT or MRI determines whether acute stroke is present. If within 4.5 hours of symptom onset and no hemorrhage on CT, thrombolytic therapy, TPA, can dissolve clots and restore blood flow, dramatically improving outcomes if given early. Beyond 4.5 hours or for large vessel occlusions, mechanical thrombectomy, physically removing the clot with specialized devices, can restore flow up to 24 hours after onset in selected patients. If TIA is diagnosed, symptoms resolved before imaging, urgent workup identifies stroke mechanism, including carotid ultrasound for stenosis, echocardiography for cardiac sources of emboli, cardiac monitoring for atrial fibrillation, and MRI to detect small infarcts causing symptoms. Sign number 3, one-sided weakness or numbness lasting minutes, then resolving completely. Sudden weakness or numbness affecting one side of the body represents another classic stroke symptom that seniors often dismiss when symptoms resolve quickly. This mistake can be fatal because transient unilateral weakness or numbness indicates TIA requiring emergency evaluation within hours to prevent major stroke. The mechanism involves ischemia to motor or sensory cortex in the brain hemisphere, opposite the affected body side. Right brain controls left body, left brain controls right body. Motor cortex ischemia causes contralateral weakness affecting face, arm, and leg to varying degrees, depending on which arterial territory is ischemic. Middle cerebral artery distribution strokes cause more arm and face weakness than leg. Anterior cerebral artery strokes cause more leg weakness than arm. The pattern of weakness reveals which vessel is compromised. Sensory cortex ischemia causes numbness, tingling, or loss of sensation on the contralateral body. Patients describe sensations like dental anesthesia, limbs, falling asleep, or inability to feel objects touching the skin. When these symptoms last minutes to hours, then resolve completely, it indicates that blood flow was temporarily reduced from embolus passing through or transient hypoperfusion, but then restored before permanent tissue death occurred. This is TIA, a warning that major stroke is imminent. Research from the SOS-TIA study published in Lancet found that immediate evaluation and treatment of TIA patients reduced 90-day stroke risk by 80% compared to delayed evaluation. The benefit came from urgent carotid imaging, cardiac evaluation, and initiation of antiplatelet therapy, statins, and blood pressure control within 24 hours. What you must do if experiencing sudden one-sided weakness or numbness, even if it resolves within minutes, is call 911 immediately without waiting to see if symptoms recur. Do not drive yourself or have family drive you. Stroke can worsen during transport, and paramedics can provide care en route. At the emergency department, rapid assessment determines whether you're having acute stroke requiring thrombolysis or thrombectomy. If symptoms have resolved, TIA workup proceeds urgently with carotid imaging, echocardiography, and cardiac monitoring. High-risk TIA features requiring hospital admission include symptoms lasting longer than 1 hour, multiple TIA episodes, large vessel stenosis on imaging, or ABCD2 score greater than 4, validated risk stratification tool considering age, blood pressure, clinical features, duration, and diabetes. Sign number 2. Memory problems or confusion appearing suddenly over hours to days. Sudden onset of memory problems, confusion, or disorientation developing over hours to days can indicate stroke affecting specific brain regions, including hippocampus, memory formation, thalamus, relay station for memory and consciousness, or posterior cerebral artery territory, occipital and medial temporal lobes. Unlike gradual cognitive decline from Alzheimer's disease developing over years, vascular cognitive impairment from stroke appears suddenly with stepwise worsening after each vascular event. The mechanism involves strategic infarcts in brain regions critical for memory and cognition. Bilateral hippocampal infarcts cause severe anterograde amnesia, inability to form new memories despite preserved remote memory. Patients cannot remember events from minutes ago, but recall childhood clearly. Thalamic infarcts cause profound confusion, disorientation, and executive dysfunction from disruption of thalamocortical circuits connecting thalamus to frontal lobes. Patients are awake but seem detached from reality, unable to follow conversations or complete simple tasks. Posterior cerebral artery strokes affecting medial temporal lobes cause memory impairment and visual deficits including inability to recognize faces, prosopagnosia, or objects, visual agnosia. What makes these strokes dangerous is that family members often attribute confusion to urinary tract infection, medication side effects, or just aging, delaying evaluation for days while brain tissue continues dying. Research shows that posterior circulation strokes have higher rates of misdiagnoses in emergency departments compared to anterior circulation strokes because symptoms are less recognizable as stroke. Dizziness, confusion, and memory problems get attributed to benign causes, delaying imaging and treatment. What you must do if a family member develops sudden confusion, memory problems, or personality changes is insist on brain imaging to rule out stroke. Don't accept reassurance that it's just a UTI without actual evidence. Confusion alone is not a UTI symptom in absence of urinary symptoms. At the emergency department, CT may miss small posterior circulation strokes, so MRI with diffusion-weighted imaging should be performed if stroke is suspected clinically despite negative CORT. Treatment depends on stroke mechanism, but typically includes antiplatelet therapy, statin therapy, blood pressure control, and treatment of atrial fibrillation if present as embolic source. Sign number 1, difficulty swallowing or choking on food, indicating brainstem ischemia. Sudden difficulty swallowing, dysphagia, or choking on food and liquids that were previously swallowed without problems represents a critical warning sign of brainstem ischemia from vertebrobasilar insufficiency or stroke. Swallowing is a complex coordinated process requiring precise sequencing of over 25 muscle contractions controlled by brainstem cranial nerve nuclei. The swallowing center in the medulla orchestrates this sequence, and ischemia to this region causes immediate swallowing dysfunction. Symptoms include food sticking in throat, liquids going down the wrong pipe, causing coughing, sensation of obstruction in throat despite no physical blockage, and fear of choking, making eating anxious and avoided. The mechanism involves vertebrobasilar insufficiency, reducing blood flow to lateral medullary regions, where cranial nerves controlling swallowing reside. The glossopharyngeal nerve, vagus nerve, and hypoglossal nerve all require adequate oxygen for proper function. Lateral medullary syndrome, Wallenberg syndrome, from posterior inferior cerebellar artery occlusion causes characteristic symptoms including dysphagia, hoarseness, vertigo, ipsilateral facial numbness, contralateral body numbness, and ataxia. This constellation of symptoms is highly specific for brainstem stroke. What makes dysphagia particularly dangerous is aspiration risk. Food or liquids entering the airway instead of esophagus causes aspiration pneumonia, a leading cause of death in stroke patients. Additionally, Fear of choking leads to inadequate nutrition and dehydration, worsening overall health. Research shows that dysphagia occurs in 25 to 50% of acute stroke patients and predicts poor outcomes, including increased mortality, longer hospital stays, and higher rates of nursing home placement. What you must do if developing sudden swallowing difficulty is seek emergency evaluation immediately, especially if accompanied by dizziness, voice changes, or facial numbness. These symptom combinations indicate brainstem stroke requiring urgent treatment. At the emergency department, swallowing assessment by speech-language pathology evaluates aspiration risk and determines safe diet consistency. Brain imaging identifies stroke location and guides treatment. If brainstem stroke is confirmed, treatment includes thrombolysis or thrombectomy if within treatment windows, antiplatelet or anticoagulation therapy depending on stroke mechanism, and swallowing rehabilitation to reduce aspiration risk. These 8 cerebrovascular disease signs seniors ignore predict imminent stroke, sudden severe headache from hemorrhage or dissection, transient vision loss from carotid emboli, unexplained dizziness from posterior circulation ischemia, lower back pain with bladder urgency from vertebral artery disease, difficulty speaking from language area ischemia, one-sided weakness or numbness from motor cortex ischemia, sudden confusion from strategic infarcts, and difficulty swallowing from brainstem ischemia. The pattern connecting these signs is that they represent brain tissue crying out for oxygen before permanent damage occurs. Recognizing and acting on these warnings prevents catastrophic strokes through urgent vascular assessment and intervention. Don't dismiss these symptoms as normal aging or stress. Every one of these signs warrants emergency evaluation with brain imaging and vascular studies to identify treatable causes before major stroke occurs. Which sign did you recognize? Comment below sharing your experience. Share this video with seniors who need this information. Subscribe for more stroke prevention content. Thank you for watching this video about cerebrovascular disease signs seniors ignore. Recognize these warnings and seek immediate medical evaluation to prevent stroke.